Good morning, everyone, and thank you for joining us. It's a pleasure to welcome colleagues from across the World Bank, International Monetary Fund, and the Civil Society Policy Forum, as well as our distinguished guests, both here in Washington and joining us online, to today's session on investing in people, mental health as a foundation for economic recovery. We're especially grateful to have such a diverse group of practitioners, researchers, and policy leaders in the room, because this conversation sits at the intersection of all three. Today is not just about ideas, but about how those ideas translate into practical, scalable solutions in complex and fragile settings. To briefly walk you through how we'll spend our time together, we'll begin with a short guided grounding exercise, which is designed to bring into the topic not just intellectually, but experientially. We'll then move into a quick interactive Mentimeter survey, so we invite you to have your phones ready. This will help us capture your perspectives in real time and anchor the discussion in the priorities of this audience. From there, I'll offer a few framing remarks and introduce our outstanding panelists who bring perspectives from frontline implementation, rigorous evaluation, and global policy. The core of our session will be a moderated panel discussion where we'll explore how mental health influences productivity, workforce participation, and ultimately economic recovery, particularly in conflict-affected contexts like Ukraine. We'll then open the floor for questions, and after that, transition into small group discussions. This is an important part of the session, so we encourage everyone to participate actively, as the goal is to move from reflection to practical ideas. We'll close by bringing key insights back to the full group and highlighting a few takeaways to carry forward. So with that, let's begin by grounding ourselves in the topic, and I'll hand this over to my colleague, Olga.
Hi, everyone. And maybe I'll... Does this mic work? Okay, that's good. Yeah, everyone can hear me. That's all. Okay, so my suggestion to start this panel discussion with grounding exercise. So let's take a quick minute to reset and to refocus. And we will do a simple breathing exercise to help improve focus and reduce tension. And before we begin, I invite you to place both feet flat on the floor, just to help you feel a bit more grounded and stable. And if it feels okay, gently soften your gaze or close your eyes. Take a normal breath in and out. Now we will start a square breathing. Breathe in, 2, 3, 4. Hold, 2, 3, 4. Breathe out, 2, 3, 4. Hold, 2, 3, 4. Breathe in, 2, 3, 4. Hold, 2, 3, 4. Breathe out, 2, 3, 4. Hold, 2, 3, 4. Breathe in, 2, 3, 4. Hold, 2, 3, 4. Breathe out, 2, 3, 4. Hold, 2, 3, 4. Now gently open your eyes. Let your breathing return to normal. Take a moment to notice how you feel, perhaps a little bit more steady and focused. And when you're ready, bring your full attention to the room. Thank you.
While that was a simple exercise, it underscores something quite important. Even brief, low-cost interventions can help improve focus, regulate stress, and support day-to-day functioning. When we think about this at the level of human capital, those small gains begin to compound. Over time, they translate into stronger productivity, greater workforce participation, and more resilient economic recovery. So before we move into the panel, we'd like to administer a quick Mentimeter question on the screen. So please feel free to share your responses as they'll help frame the discussion ahead.
This one?
Let's keep it up for just a minute.
Okay.
So good. Thank you for your participation. It seems that education, human capital, mental health, and health certainly are the most prominent. Since the pandemic, and more than 11 years after Russia's unprovoked and unjustified invasion of Ukraine, human capital across the country and beyond remains under sustained pressure. More than half the population in Ukraine is experiencing mental health challenges, and this is not abstract. It's shaping how people learn, how they work, how they cope, and whether they remain economically active. We're all familiar with the importance of human capital under normal circumstances, how it drives productivity, growth, and resilience across every sector. But today, we want to explore what happens when human capital is placed under prolonged stress, during conflict, and in transition to recovery. The key question we would like to explore today is if economic recovery depends not only on infrastructure and financial capital, but on human capital. How does mental health shape productivity, workforce participation, and ultimately economic growth? To explore and answer this question, I'm joined today by an exceptional panel. First, to my left, we have Caroline Averch, a senior technical advisor at FHI 360, a leading global development organization. She served as project supervisor for an excellent cost-benefit analysis on mental health and psychosocial support and its role in Ukraine's economic recovery, commissioned by People in Need. She brings a rigorous perspective on how investments in mental health can translate into measurable economic outcomes. Next to her is Olga Yudina, founder of UA Mental Help, a Ukrainian organization launched at the onset of Russia's full-scale invasion in 2022. In just 4 years, with a network of more than 80 certified psychologists and psychiatrists, UA Mental Help has supported over 23,000 individuals with mental health and psychosocial support services, largely delivered remotely, and has developed innovative youth-focused digital tools, which Olga will share more about shortly. We also have with us, joining us, Olga Khan, who is joining us remotely from Ukraine. She is a World Bank mental health consultant based in Kyiv. Her work spans global mental health, emergency MHPSS, and applied public health research, helping to bridge frontline realities with broader economic and systems-level insights. And finally, We are honored to be joined today by Alaka Holla, lead economist in the People Vice Presidency at the World Bank and program manager of the Strategic Impact Evaluation Fund. Her work leverages rigorous data-driven evidence, including randomized evaluations, to inform policy across health, education, and early childhood development, with a particular focus on how investments in human capital translate into measurable economic outcomes. So Carrie, if I may start with you, please. Building on this idea that economic recovery depends not only on infrastructure and financial capital, but on human capital, can you help us understand from an evidence perspective how mental health is shaping productivity, workforce participation, and broader economic recovery in Ukraine?
Yes, thanks, Ramon. I'm really excited to be here today. Is this mic working?
It's working, but it's kind of close.
Good morning. I'm very excited to be here today to talk about some of our most recent research, which we found quite compelling, not just for the case of Ukraine, but for potentially other conflict-affected areas that may benefit from this type of simulation model. So I wanted to back up and just explain that FHI 360, as a global nonprofit human development organization, has three major impact areas: economic resilience, global health, and crisis response. And as we've seen over the past 3 or 4 years particularly, and maybe increasingly more so, the intersectionality of some of those areas and the types of solutions and approaches that we need to provide to help people not just stabilize, but to actually recover from some of the current situations they're facing is quite important. We have been looking at mental health and psychosocial support as a non-health sector, but rather a cross-sectional type of work that we are interested in exploring more through our research and implementation. Over the course of the past couple of years, we began conversations with a very interesting organization called People in Need, which is a Czech-based nonprofit organization that we consider to be one of our sister organizations in Ukraine particularly, since we were both delivering similar types of humanitarian assistance and crisis response supports that ranged from everything from food, water, sanitation, shelter, and both of us had similar types of approaches for mental health and psychosocial support based at the community level and building up community resilience to help self-solve and sort of contain support through a variety of very evidence-based approaches. PIN, I'm hoping one of their board members may be here shortly, but they have been a terrific partner in terms of helping us build out a simulation model that I think will be of interest to some of you as you think about mental health as a driver for human capital and labor productivity. So I think maybe with that, oh, perfect. So I just wanted to make sure we were all grounded. I know I'm at the World Bank IMF meetings, but just to make sure we're all talking about the same things, I wanted to just point out the sort of complement and inputs of physical and mental health into human capital, which we consider to be the economic value of skills, knowledge, experience, and personal attributes that drive economic productivity. For this simulation model that we built out, and I'll give you a little preview of the methodology, but not all the details in this session, we utilized PIN's data from their mental health and psychosocial support programming across a continuum of typologies. They have a direct mobile unit that provides mental health support. They have a hotline, which you'll hear a little bit more about the hotline model and its value through UA Mental Health. They also have kind of an emergency relief team of psychologists that goes in with early responders to help communities and individuals recover from that. So it's the combination of those efforts that we utilize for our simulation here. So when we looked at economic productivity, we really looked at it from kind of the labor standpoint of employment. Yes, no, are you employed? We looked at it from absenteeism and presenteeism, which have a similar correlation and effect on labor productivity, and overall earnings over time. And so we went about this research, again, there's only a couple slides in here, and I'm happy to speak about it later. We basically did a full-scale lit review, looked at all of the published scholarly journals. We did research on the gray literature as well, and found almost nothing, actually, that looked at this topic. So that was finding number one, is that we found very few studies that had actually correlated these two things together at all. And then what we did find was useful in terms of just helping us extrapolate and interpolate how the effect sizes and kind of the conflict setting of Ukraine might be modeled into a simulated kind of scenario. So I think there's a piece up here. Maybe we could switch slides. I'm going to give you the punchline up front so that we can maybe just talk about some of the elements and factors that fed into it. But we looked at these 7 areas, really, that were looking at the potential benefits of mental health and psychosocial support as a contributor to labor productivity. Again, breaking down employment into a few factors, working more hours maybe than if they had had an intensive mental health disorder, working more just in general, and working better, as in not just mental health disorders, as many of us know, often have the impact of being you're present at work, but maybe not fully at your highest potential. We also looked at lower future medical costs, less care needed from the family unit. And so we're going to explore sort of how the family plays into a healthy, productive member of society later on in Alaka's presentation as well. And while it was a very difficult subject to tackle, we actually estimated the economic value of reduced suicides, not just in the economy itself and labor productivity, but within the household, how that might impact others' ability to, again, maybe not suffer as dire impacts from absenteeism or presenteeism, due to that creating even more mental health stress. We took a lot of the PIN data. We took a quantitative sweep as well as a qualitative sweep, including interviewing a number of their psychologists, their frontline workers, some of their participants, to fill in gaps. But the key measures, I'm not sure how many of you are familiar with the mental health pyramid that is kind of the interagency standard, but PIN effectively works on the 3rd tier, focused on community, and kind of the community is the basis for resilience, ensuring that group support and social support can be delivered not just by psychologists or the hotline, but rather at the community level. So we took their inbound surveys and outbound surveys regarding the Kessler scale, which is the general metric used in mental health and psychosocial support programming that indicates kind of a light to moderate kind of mental health disorder of some type, a mid-tier, and then one that requires clinical referral. And so we estimated their participant group when they were surveyed, when they came in, what their Kessler score was, when they exited the program, what their Kessler score was, and then rounded that out with other pieces of the PIN puzzle, which included their full operational costs, including staffing, the mobile units, all of the investments that their donors and funders were making into that type of programming, which extrapolated the cost that you see here. I think what was exciting, and I think there may be one more slide about this. Actually, hold on that 1 second. Ron.
Okay.
I was just going to say that I think it was quite interesting. I'm not sure how many of you are familiar with the Ukraine particular labor market dynamics, but not only have they suffered through a prolonged conflict situation for 4+ years at this point, but their labor markets are severely distorted. And so this is a particularly interesting case study because they've got a huge population that's externally displaced, just had to move to Poland, Moldova, wherever they moved. They have a huge population that's constantly internally displaced and moving around the country, again, delinked maybe from their more secure traditional jobs. And they have a whole pool of usually young men that have been in the military, are about to be back in the military, or coming out of the military, that are veterans in need of rehabilitation. And again, re-entry through both traditional as well as mental health and psychosocial support to get them kind of back to stability, and then hopefully becoming more, again, returning to labor productivity. So this population group has all of these dynamics going on, and mental health and psychosocial support has been prioritized, as you may have heard from the Ukrainian government, quite a while ago by the First Lady in particular, and we had quite a bit of engagement with the Ministry of Health and the Ministry of Economy team that is working on trying to adjust the labor to be as productive as it can with the people who remain that can be activated in the workforce. It is critical for Ukraine's survival right now, and it is critical for their future economic recovery. So I think with that in mind, maybe we could just share the next slide, please. I wanted to point out we did take a look at the studies that focused on more traditional clinical-based mental health and psychosocial support. And as you can see here, actually, some of the investments are relatively low compared to what our findings were in both a conflict-affected setting as well as using the type of modality, the community-based interventions that PIN was using. These are widely published studies. We also took a look at data that had been synthesized out of the World Bank Open Data Pool and took a look at some of those studies for comparable investments that, for example, World Bank, IMF might make in, for example, infrastructure, which generates something of a benefit cost ratio of about 1.5 to 4 for every dollar put in. We took a look at early childhood education, so we'll talk a little bit about that, and that was around 6 to 1 for each dollar invested. That's a very popular investment because it generates great returns. Vaccination programs, for example, generally speaking, generate about 10 to 1, something like that. But what we found, the clinical care ranges, as you can see here, are really around 3 to 8 in terms of investment and return on investment. The type of programming that PIN is delivering, which is very important in this particular setting, similar to what FHI 360 has been delivering with the outreach and multiple entry points, 24/7, making sure that people can both be responded to and move forward. It generates what we think to be a relatively conservative estimate of 17.6. Again, we benchmarked this off of PIN's data only. We've not even, run the simulation on our own data at FHI, but this, I think, at least points us in the right direction. I think we made a few recommendations, and I promise I'll close. So a few of the key recommendations that I think will be discussed here is really focusing on the systems, so not making just investments in one type, but looking at a system, the household, the school, the community, and actually the workplace to make sure that there's kind of that wrap around and no one falls out of the mental health psychosocial support pyramid or system. We also talked quite a bit about utilizing programmatic data more effectively to get the employment, earnings, and productivity pieces that we need to really make this simulation more rigorous. And we also talked about just generating more dialogue and more evidence around this topic, both the kind of more traditional literature as well as just implementing partners, sharing what they have, and maybe taking this simulation model, which we're happy to share, and running your own data through it, which I think could be quite interesting. Thanks.
Thank you, Carrie. Actually, now I have a follow-up right to that. How can this model be used by development partners, government, CSOs, and other stakeholders to consider the economic benefits of NPHSS?
Yes, well, I'm hoping that through today's session, we'll be able to trigger a discussion that I hope will flow through to a session that's being held tomorrow, I think on labor productivity that's much more skills, et cetera, oriented. I think that donors particularly, and governments, like the government of Ukraine, who's very interested in this type of work, really should thoughtfully consider their investments and maybe the way that they are layered together. So rather, for example, than making just a core infrastructure investment in roads, rather look at the complementary community-based investments that could be made, including a piece mental health psychosocial support that could be layered into that. So I think that's important for donors and other investors to consider. For governments, I mean, I think the case is clear in Ukraine. The government has already noted its keen interest in this model. They actually participated in a presentation of this and are very keen to pursue. I would say that implementing partners, again, we're happy to unpack the simulation model, and you can use that model to input your data. I guess I would say outside of Ukraine, we see many, many disruptions in the world right now. I think that the takeaway for me is actually making sure that this is infused into programming no matter what sector you are working on. Crisis response programming, whether it's sanitation or food delivery, really needs to include this to help people get back on their feet, start earning an income and make sure their household is economically resilient, not just fed and sheltered.
Thank you, Carrie. That's actually really interesting and very helpful recommendations. Let me build on that and turn to Alaka. Alaka, in your new report, Building Human Capital Where It Matters, you emphasize the importance of settings. From your perspective, which settings are most influential for human capital outcomes, particularly in mental health?
Yes, thank you, Roman, and thank you everyone for your time. So here, maybe you can switch the slide. So at the World Bank, we do have a new report out focused on human capital. And we are, so you can access the report and complementary materials through the QR code. And what I'm going to do is I'm going to take some time just to summarize the report, and it would be really nice with all of you to reflect on what would this framework mean in a conflict setting? What would it mean in particular for mental health? Sure. Oh, sure. Okay. Yes. Okay. Yes. I will try to appear. I'll try to make sense and appear photogenic. So in this report, we are really making the case that for key human capital outcomes, like learning, like mental health, productivity, we really need to move beyond the traditional settings where we think of these things being built, so schools and clinics, and we really need to focus on how important homes, the neighborhood, and the workplace is. So for homes, when you think about it, it's the first setting where human capital is built. In early childhood, children mainly stay at the home. They're mainly supported by their family. And we know the importance of the first 1,000 days for setting children on a good human capital trajectory, whether that's their learning or their mental health. And in this report, we look at why might the home be so important for human capital. And of course, when you think about the home, homes differ on how much they can invest in their children, just their resources and how much money they have. And what's interesting in the kind of mental health context is just how important resources are even for mental health. And so if you can imagine a situation where we could just magically rain down money on a household, what would happen? There are these natural experiments that do that. And luckily there are studies that follow people over time. And when you see that, you see what you would expect. You see children getting more education, but you also see children having much better mental health. You see them fighting less with their parents, and then even if you follow them into their 30s, these children are better off economically, but this mental health impacts are lasting. So they're much less likely to have depressive disorders, they're much less likely to suffer from anxiety. But what we stress in our report is that the home is important not just for the resources that it provides, but for the care that it provides. So typically we think of when we're trying to help poor households, we try to get them more resources. And too little attention of policy has focused on the care environments of children and what policy can do to influence the care environment of children. And just to show you how important the care environment is, we look at this situation of China. And so we're talking about China here, but I just want to emphasize this is not a unique situation. So China, like many other countries, has a lot of internal migration in which children are left in the care of grandparents or other relatives. They see their parents maybe once a year when they come back for a festival. And these children are in a unique situation in that they have more resources in their home. So that was the reason for migration, to earn more money. So indeed, these children do have more resources if you look at them. But what's really fascinating, or not fascinating, kind of alarming, is that despite having more resources in the home, the human capital of these children suffers. So you see they are doing less well on tests of mathematics, less well on vocabulary, and they are reporting much higher rates of depression. And you see this both for children who are currently in this state, so who are currently not seeing their parents in the year that you interview them, but this data that we use is longitudinal. So you also see that this lingers. So if a child has been in this situation in the past, relative to children who've just always been around their parents, this sticks with them. This disadvantage in math and reading and this disadvantage in mental health sticks with them. And so for us, this is, what we find new here is that, sure, resources matter. You can redistribute resources. You can make sure poor households have higher income. But you really need to also address their care environments explicitly. Another setting that we emphasize in the report is the neighborhood. And when you first think about why are neighborhoods important, of course, neighborhoods have schools and health clinics. And so if neighborhoods differ on access or the quality of these services, for sure the people in these neighborhoods are going to have lower human capital. But what we emphasize in this report is that neighborhoods are important beyond the services that they provide. There's also the environment, like the physical environment of neighborhoods, how polluted the air is, how polluted the water might be. And there are studies that show that this directly impinges on how much human capital people can develop. You don't normally think of water quality and air quality and how much education a person has, but there is a connection among these. And then what's relevant for mental health is that we also find a huge association and causal impact of social dynamics on how much human capital you can build. So if a child is living in a very violent context, they are going to accumulate less education. They are going to obviously have worse mental health. And so just like in the home, what we said is, policy has focused so far in increasing resources for poor households. We also need to think about the care environment. What we stress about the neighborhood is that in addition to making sure services are high, the quality of services are high in the neighborhood, policy really needs to kind of integrate many different sectors. So if your goal is to increase education or to improve mental health, in addition to working with clinics and schools, you really also might need to work with public safety. You might also need to work on environmental regulation. And then finally, the last setting that we stress is the workplace. And so many people think that human capital accumulation or learning stops at school. And what we show in this chapter is that it really continues beyond age 18. And actually, most people spend most of their lives not at school, but in the workplace. And so there's a lot of human capital that's accumulating in the workplace. And this is kind of a missed area if we kind of think of it as stopping before people get to work. And what we find in the report, which I think will not be surprising to many of you given what you work on, is first, in order to build human capital at work, you actually have to be in the workplace. And there are many, many people who are not participating in the labor force in low and middle income countries. So youth is one population, so 1 in 5 youth are neither working nor in school. So they're really not having any opportunity to build their human capital. But when you look at women, 50% are not in the labor force in low and middle income countries. There's also research from my colleagues at the World Bank, I can connect you to it, from Bangladesh, I think, that there is an inherent mental health benefit to having a job, right? In addition to earning money and having that kind of make you feel income secure, just the idea of having a job is also beneficial for your mental health. So, one area of policy focus that in order to build human capital, not just for current productivity, but to build human capital, is to get these people who are not participating in the labor force, particularly youth and women, into jobs. But what we show is that even when people are in jobs, there are different types of jobs. There are jobs that facilitate learning, right? So if you have, a lot of peers that you can learn from, if you have technology that also makes you kind of up your level, if you have managers that, some kind of layers that can, foster mentorship and all of that, you can learn on the job. But most people in low and middle income countries are in very small scale self-employment, right, with very limited opportunities for learning. And so that's one thing that we stress in our report, is that both you need to get people into work so that they can continue learning at work, but also you need to increase learning at work. And so that's kind of the report in a nutshell. But if you think about what happens in conflict affects the home, right? So it often splits families apart. It often compromises the mental health of caregivers, and we know that there is both associative and causal evidence that when a caregiver's mental health is compromised, the care that they give to children also gets compromised, and therefore the mental health of the child gets compromised. When you think of neighborhoods, of course, that's very obvious. There's often during conflict, there tends to be a lot of violence in neighborhoods, a lot of services, our services shut down, and people don't have access to services, in addition to the actual shock of violence and what that does to both mental health, but also, as I told you, education and other ways to accumulate human capital. And so I encourage you to, and as Carrie mentioned, in the workplace, when people have to leave, right? Either leave their children to migrate for work or switch jobs perhaps to a lower learning job. This, in addition, even after the conflict has stopped and they get reattached to more stable employment, the fact that so much human capital accumulation happens at work, and the fact that work gets disrupted during a conflict, whether people are in work or whether they're in like a lower learning type of job, this is kind of gives you a good framework, I think, looking at the home, the neighborhood, and the workplace for kind of assessing how kind of conflict might kind of compromise all these settings, and how when we are recovering from conflict, in addition to kind of reopening schools, reopening clinics, restoring services, we also need to kind of restore damage to the extent that homes and neighborhoods and workplaces are also building human capital.
That point on conflict in home and neighborhoods and workplaces is really, really important. Thank you, Alaka. Olga, Yudina, we've heard about economic frameworks for mental health investment. From your experience leading UA Mental Health as practitioners, your team on the ground has built this in Ukraine in the middle of an active war. What does the gap between policy ambition and operational reality actually look like, and what does it take to close that gap?
Thank you, Roman, and thank you everyone for being here. And I want to say that if I knew how big this gap would be, maybe I even didn't start this project. But jokes aside, the gap is as is. So the framework exists, but when the crisis hits, there is actually no system fully ready to deliver this response. And sometimes you need to build your response and during the active phase of the conflict. And our work began in the first 72 hours of full-scale invasion of Ukraine. And in the earliest weeks, we focused on two things. So first one was mass outreach. Because during the crisis, social media becomes a critical coordination tool. And we use this to reach people at scale, to provide immediate, accessible guidance on managing stress, on first psychological aid, on how to support your children in a bomb shelter, and also connect people to referral pathways to get necessary help. But very quickly, the only information wasn't enough. We started to receive requests for counseling, for emotional support. And so this is when we launched very quickly with the help of tech volunteers. We built a platform that enabled people to access free psychological support when they need it. So these two things becomes like a foundation of our crisis response. But as the situation evolved, it became clear that it's like not short-term emergency. And with ongoing war and continuous threat to life, we had to move beyond the immediate response. And so in 2023, we expanded our focus, and we moved on the top of crisis response. We also started to build programs aimed for more long-term recovery. And we have to make a few strategic decisions. So first, we have prioritized children and youth, because these are the generations that will be taking an active part. Oh, it's because it's close. Yeah. Okay, that makes sense. Thank you. So it's still, yeah, exists. How it's now, okay. Yeah. I have some notes here, but I don't know how to. Okay, is it now? Okay, it's okay. Okay, good. Yes, so we focused on children and youth because this is will be the generation that will be taking an active part in rebuilding Ukraine. And our approach is also guided, like Carrie previously mentioned, by IACC standards and the parameter of psychosocial intervention. And so our approach with the children was prevention first. And we wanted to be where young people really are. So first we introduce specially designed lessons at schools and universities to help children and young people build self-help skills, build psychological resilience, to learn how to talk about mental health to their peers. And what we have saw from this is that we visited that there were like a really strong results in knowledge gained. And at the same time, we focused on digital care. So we've launched a chatbot, so young people can like text us. We developed a mobile application with self-help modules grounded in CBT, mindfulness, and other evidence-based methodologies. And this app has like an AI layer on top of the educational models, but the AI acts more as their skill building and guidance rather than substitution for therapy. So we use it like more like a bridge, and also in this app. Youth can connect with a life counselor. So when we launched this project, in the first 4 months, we had 4,000 users and 546 access life counseling. So it's like 1/4, which is a really great result. And when we started supporting young people, so it becomes clear that supporting like young people, we need also support the adults who are care for these children. It's like families, caregivers, teachers. And for example, we surveyed mostly 500 teachers and found that 2/3 of them need psychological support, and nearly half are already emotionally exhausted. And this is a people who care for children like every day. And this is actually what came as a foundation of our programming. So we focus on the one group. We discover needs. We discover what are needs like not met, and follow their chain of care of what's next. And this is actually also how we started to care about frontline workers. So we started to work with teachers, then humanitarian workers, social workers, and other people of helping professionals. We call this program Help for Helpers. And recently we launched also a pilot program for healthcare workers in one of the regions in Ukraine. And so there were like 97 participants, mostly doctors and nurses. This is the pilot program, but the results were significant. Emotional exhaustion dropped by 42%, depersonalization by 44%, total burnout by 22%, and traumatic stress by 22%. But what's most important is that compassion satisfaction rates, they grew by 18%. And this number really matters because well-being of mental health providers depends not only on the work stress, but but also on how they feel about their work, how they see value in their work, and if they see meaning in their work because they facing patients like every day. And as of today, we supported more than 27,000 beneficiaries due to the also remote nature of our work, we supported also 90% of our beneficiaries are in Ukraine, but 10% abroad. So to sum up my answer, so every program and every pilot that we run, it moved us to the next design. And to close this gap between policy and operational reality, you need to build, you need to adapt, you need to learn, and then launch again to make sure that this gap is fully closed.
Okay, thank you, Olga. Ukraine may be considered an extreme case, long-term, active conflict, massive displacement, destroyed infrastructure. How much of what you've built is specific to the Ukrainian context, and how much of it translates to other post-conflict or fragile state recovery settings?
So my answer is that the context is fragile, but actually the architecture is not. So during our work and during our experience in Ukraine during these 4 years and experience shaped by wars, so we design something that we can name as a 3-component model of MHPSS structure. So our first one is services. So it could be like any services, accessible, scalable, like digital help, self-help, helplines, chatbot-based counseling, targeted programs. There are many, but the goal is to meet people where they are, so they can receive help when they really need it. Second component of this model is education. So it's about capacity building and about capacity building. And we work on 2 tracks here. So first we work with counselors, but not in a clinic way, and more in an evidence-based way to help them teach crisis-sensitive and conflict approaches. And the second one is equipping frontline professionals like teachers, healthcare workers, social workers with the skills necessary to recognize distress, to respond appropriately, and to talk about this with their patients. And this is actually where the multiplier effect happens, because one trained teacher can help hundreds of children, and one trained doctor can help hundreds of patients. And third component of our model is research, because this is actually really where the magic happens, and every company we implement is accompanied by data collection and evaluation, and we assess short-term results, and now more and more we want to also assess the long-term results, and this is help us understand what works, what don't, and why. And this 3 components, services, education, and research, they form a loop. So data informs how we train, better training improves services, better services generate better outcomes, and those outcomes feed back into the research, and the system improves itself. So, and this model, it can be replicated in any conflict sensitive region.
Okay, thank you. Based on everything that you've seen and built, in your opinion, what's the single most common mistake that governments and international institutions make when they try to integrate mental health into recovery planning?
So I'm not sure that this is maybe a biggest mistake, but one of the mistakes that I see is that this work is usually treated as humanitarian project, and if we view this as humanitarian project, it means that it's short term. It has some specific budget, and when the budget tightens, it's usually the first thing that's got cut. So I think the other approach is to treat this as an infrastructure the same way as we treat building roads, building hospitals, and this is when we treat it as an infrastructure, it means that we can properly design it, properly build it, and have better and more long-term outcomes for our communities. But actually, this is also a great question for our Q&A. So I would welcome a conversation about this. So how we can make sure that this is further will be treated not only as a project and humanitarian effort, but as an infrastructure.
Thank you, Olga. That's actually a really important point that we'll come back to. Olga Khan, thank you for your patience. Building on what we've heard from the front line and the evidence, given your long-standing engagement with Ukraine's mental health system, from reform to crisis response and now recovery, what are the most critical system-level lessons for integrating mental health into national recovery efforts?
Thank you. And first of all, can you hear me?
Yes.
Perfect. Yeah, thank you for a question. And actually, following the suggestion to discuss the question Olga just answered, I have to contradict her and answer on your question because I think that coordination is super important, and strong coordination between humanitarian response and government-led system is essential. And since the full-scale invasion, Ukraine actually has demonstrated a strong example of aligned efforts to build a really strong system and scale up of services for rapidly emerged needs in mental health services, and actually build a program of on a primary health care level. This actually, I would say, one of the lesson learned and best practices, what I would recommend to scale up and continue in other contexts. And also, second one, I would mention the strong government leadership is crucial. As it was mentioned before by one of the speakers, that Ukrainian government treats mental health for a long time. It was actually unrecognized, but after full-scale invasion, actually government understand that mental health is crucial, and the First Lady initiative pick up and put this topic on the top of the agenda, and actually government put the mental health as a cross-sectoral policy priority, which helps to build and mainstream mental health in all policies. So I would say this will be the answer.
Thanks, Olga. So it sounds like Ukraine has effectively turned a crisis into a real-time testing ground for mental health system reform. What has actually worked in mainstreaming mental health at scale, what has not, in closing the gap between need and access?
Thank you. Let me start with data, because it will help us to define the progress, achievements, and actually challenges. So we know that since the full-scale invasion, up to 30% of population is estimated as affected by mental health conditions. Also, by some studies, we know that around 40% of people are in need of mental health support. However, only 8% are rich and seek for help. So this is the gap which we have as one of the crucial one. And to address this gap, Ukraine did actually tremendous change on a system level. And first of all, during the war, ongoing reform with mental health shift from the centralized psychiatrical model to decentralized community based and primary health care based approach, which are more cost-effective and scalable. Ukraine did tremendous change in integration of mental health on the primary health care and on the community, and opened the network of national mental health centers across Ukraine. Also, capacity building project built more than like 12,000 of family doctors and nurses on MHGAP program. At the same time, mental health treated not only within the health sector, but also within the social protection service, where resilient centers provide mental health support. Ministry of Veterans launched their program to support mental health for veterans, and it helped to build the coherent approach. And on the legislation side, it was also strong connected, because national coordination mechanism was established, and new mental health law, which were developed during the wartime and endorsed in 2025, actually recognize mental health as a cross-sectoral policy priority, which is critical because it moves mental health from the donor-driven and humanitarian mindset to the sustainable system architecture. And when we speak what works, what not, we see, I mentioned already the gap between needs and actually utilization of the system. We see that we still have some financial barriers, service disruption, and probably last but not least, stigma and low mental health literacy when people not seek for help. From the system perspective, this tells us expanding infrastructure alone is not sufficient, and the system must also address demand side constraints, financial protection. So to summarize, Ukraine did a lot. Government treat mental health very seriously. However, we also see that it's a real example that rapid scale up is possible in a crisis context. But now we should see on the next phase the fundamental about system performance. The real test is whether the system can move from training providers to delivering effective care, from expanding services to increasing utilization, and from investing resources to generating measurable economic returns. Because the task is not only to build a good mental health system, but to restore and protect the country's human capital at a scale which is a foundation for long-term economic recovery.
Thanks, Olga. One quick final question. If the trajectory continues the way it's moving now, what would be the most visible economic signal of success in 5 or 10 years? And what risk does Ukraine face if it fails?
Yeah, thank you. And I think I can echo to some of previous speakers who were about human capital before. And I think it should not be something abstract. It should be a very measurable recovery of human capital. Just back to statistic which I mentioned, and the gap between needs in mental health support and actual sick care. This is not just a health gap, but it's a productivity gap. And economically, this means that the large share of population who struggle with mental health probably currently functioning below their full cognitive and emotional capacity. This affects how people learn, how they work, how they make decisions, and also whether they can remain economically active at all. These challenges translate directly into lost productivity and reduced human capital. The system is currently absorbing significant but mainly invisible economic cost. So this is a task to Ukraine to close the gap, which will means in 5 years. These people who would otherwise drop out of the labor force or able to stay engaged, workers are more focused, more resilient, and more productive. Fewer people with health life and lost to depression, anxiety, and trauma. And over time, lower pressure on the healthcare and social protection system, because early intervention prevents long-term disability. On the opposite side, with a kind of negative scenario, if Ukraine fail integrating mental health into its recovery, the risks are equally clear. We will see the significant proportion of people, especially veterans, IDPs, who will remain either outside of labor market or unable to fully participate in it. Also, we will have untreated mental health conditions which are strong correlate and comorbid with cardiovascular disease and other non-communicable diseases, can lead to a reduced life expectancy, and which will cost much higher to health system. Also, children growing up in the constant stress condition could, without adequate support, more likely experience disruption in education and poor health, which actually will lead to a future workforce, not just current one. If treat mental health, investment in mental health as economic infrastructure, integrate into primary healthcare, education, workforce, and community, then it becomes something very different, a long investment with a measurable returns. And ultimately, difference between these two modalities, success and failure, are quite stark. So success means that Ukraine can rebuild not only its cities and institutions, but also the functional capacity of its people, leading to faster and more inclusive, more resilient economic growth.
Thanks very much, Olga. Now I'd like to open it up to questions from the audience. Wow, too many hands. Okay, you're first. Oh, sorry, there's a microphone over there. Could you please? Thank you.
We're live streaming the event,
yeah.
So we can hear you. We want to make sure.
And might as well line up. I think that's probably the fairest way to ask questions.
Please, thank you.
It's good to see you.
My name is Megan Gardner from Cultura Connector. Olga, thank you for meeting with me yesterday. Our organization makes therapeutic games for children. And one thing we've found in Europe is that when the kids learn how to play these games and they're facilitated as participants, that they go on to then make their own games and facilitate them. And so you essentially have what we call a contagious cure. So I was wondering if there are any interventions that are currently happening that are being measured in that way, where the participants who are receiving the services are receiving skill building techniques and then going on to help others with those same skills. Thank you.
We had not labeled it a contagious cure, but I really like that. We have done some similar work to UA Mental Health in terms of training those who are providing education at different levels, primarily in the TVET system and some of the schools, the technical schools, through which we were delivering a workforce development program, because again, we were looking at psychological first aid, immediate response, kind of 2022, 2023. That then expanded in terms of just teachers training other teachers, the youth who were participating in the TVET programs working with each other, and kind of these group-based, very organic types of situations ended up looking like that. Maybe it wasn't a game, but maybe a talking group over coffee, for example.
Right.
So I think it is happening. I don't know that it's been well documented.
Yeah, it's amazing. It's an exciting opportunity. Thank you.
I would like to add on this one that there are usually different types of measurements used, and there are some widely accepted protocols for measurement, psychosocial intervention, before and after. But I think the most the most reliable method is randomized controlled trials, and maybe Alaka can tell more about this one.
Yeah, sure. So we do have an example in this portfolio that we fund of randomized control trials from Ukraine, where during the crisis, they were giving kids online tutoring. And they set it up so that, you know, they knew they would have to adapt the program. So they gave them online tutoring in small groups, right, with their peers. And they, you know, from the first to second iteration, I think they changed how, like, the academic content of the tutoring. And from the second to third variation, they changed whether they did psychosocial support. What I found so fascinating was that even just the pure education intervention, just giving children this opportunity to come together in a small group with an online tutor and not have their education completely disrupted, and they were measuring outcomes, as Olga said, like, it's important to measure. Just the education interventions themselves decrease stress of the children. And the researchers they didn't explicitly design this into their experiment, but they were just exploring what are the mechanisms behind this? Why did just the, you know, meeting together? And they saw that there was this contagious meeting, right? So if they were meeting these kids for the online tutoring, it increased the chance that they met them even online for other reasons, right? And so even just having friends while you're cut off from school could decrease your stress. So I thought that might be an example. They didn't pinpoint it as like a, you know, a contagious cure, but there is some value. It wasn't in those early iterations, there was no explicit mental health content, yet it did reduce children's stress levels.
Next question, please.
Good morning. My name is Brianna Garrett. I'm with American University School of International Service. And I was thinking about the tenets of building human capital where it matters. You talked about the home. And specifically, as we think about the home, who's central, oftentimes that can be women. And so I wonder in your methodologies how you accounted for sex disaggregated data. And if so, what were some of those trends or outcomes that you saw when we account for women in intervention methods?
So that's an interesting question. It's people have opinions when you look at data. So for sure, women tend to be the dominant caregivers of children. Also, older like girls, like sisters, tend to be caregivers. So a lot of the burden of caregiving is on female members of the household. If you kind of follow the link to our report, you see we have some interactive data online where you can look up, if we have data on your country, it'll be there. We show gradients with, like, you know, maternal education and some of these human capital outcomes of children. And some of our gender colleagues would say, why are you kind of making mothers to be their sole benefit is the human capital building of children? When we look at fathers, you see similar gradients, right? So you do see that fathers' human capital affects children's human capital as well. They're just muted, right? And it's not because they're ineffective at transmitting human capital, but it's just the dominant kind of allocation of time within the household has women providing more of the care. When programs have tried to get fathers more involved, so parenting interventions that have targeted fathers, you know, rather than mothers, or both fathers and mothers, the evidence right now is really mixed, right? You know, sometimes it helps children, and sometimes it doesn't. Sometimes it backfires, right? And that doesn't mean anything there's inherently wrong with making fathers more active in the care of their children. It just means we have to work on how do we do that, right? How do you do that without antagonizing them? How do you do that in an effective way? So I think my response is more like we really don't know. If our goal is to kind of get fathers more involved in the care of children in a productive way, I think people are still gathering evidence on that.
Next question, please.
Hi, James from United for Global Mental Health. There was an interesting point on the MHCAP rollout in Ukraine, is that it's interesting to look at that from a financial policy point of view, and how the change in capitation payments to practitioners really drove that rollout. There's a really good paper on the WHO website about that if you want to know a bit more about that. But my question was on making the investment case for mental health, particularly on public investment. It's really, really difficult to do, and for so many mental health systems, we're starting at almost zero. We worked with the Liberian government a few years ago to cost up their really good national mental health policy. How much would it cost for them to actually enact that? In 2019, the budget allocation to mental health was $35,000 total for the country, of which 10,000 was spent. And when we did the costing for the mental health policy, it was going to be around 12-13% of the health budget. So we're going from zero to that, and the health financing unit in the Ministry of Health said, we're not even going to take that to the minister. Like, we can't start that conversation. So then we looked at it as a percentage of general government expenditure, and it came down to less than 1%. And then we got a conversation, and then a conversation started with the president's office, and things started to move a little bit more. But I wondered if there was experience about making the investment case. We've talked a lot about going beyond the health budget, and mental health shouldn't be the sole responsibility of the health budget to fund. So I'm really pleased to hear that, and I'm also really pleased to hear the bank talking about social determinants and a prevention approach to mental health. That's great, but in so many places we have one child psychiatrist for 1 million population. So as well as sort of investing in the home and the workplace, we also need the nuts and bolts of a mental health system. How do we get more public expenditure on mental health systems, that sort of the traditional systems that we know work, when we're going from a really standing start? So any advice from the panel would be fantastic. Thank you.
Thank you. I just have one reflection. That was an interesting way to sort of posit the very small dollar value, but within the greater context of, the overall budget. I feel like making the economic case, of course, is our prerogative. This study allowed us to sort of start eking out what the structure of that economic case would be. It is not Ukraine specific, but we actually demonstrated effect sizes from broader literature that allow us to clearly state, for example, a person suffering from even a mild mental health disorder, if they are absent or have presenteeism, they literally lose double the amount of work days, much less the quality of work and productivity. We can easily extrapolate. So Olga Khan cited 40% of people in Ukraine, for example, probably have a mental health disorder. When we did this study, WHO estimated 20%. That was still well over. So if you use 40%, that's 2 million plus people. I mean, so it's out of the residual labor pool that is left and can actually go to work. It's really an economic imperative, or they just won't be able to get the economy moving. So I think using the numbers, it's very clear. What is not there is just enough evidence. So as I said, we had a very tough time finding published literature with real effect sizes, with the translation into economic benefits. So we had to do a lot of extrapolations. The simulation model could work in other countries, for example, but what we have is what we have. And so I would just say maybe a lighter investment in evidence generation, but around that specific topic could also include other pieces of human capital development.
Next question, please.
Morning, everyone. Alejandro Lar here. My research is at the intersection of lifelong learning, investments alone throughout people's lives. Aging by definition is mistaken, because when people think about aging, think about elderly. And is incorrect. It's aging. We are all aging here. So we need to really address the issue, that we need to correct that. Technology, we use technology to accommodate the aging population means all of us. And brain sciences, because if we invest early, it was mentioned just now, prevention. Early interventions are so important, and I focus on a specific segment of the population between 40 and 60, a segment of the population that almost is left out of the equation, because we invest in early childhood, which is great. I'm not saying that it's wrong, but we're dropping off the ball at age 30, and then 40, 50, if we invest in that segment right now, incidences of mental health problems at age 60, 65 diminishes by 19%. And there's evidence everywhere for that. So if we invest in that segment of the population right now, we will have less mental health problems. And those individuals will be able to work. So we're speaking about creating jobs here. So we need to invest early right now. So I want to see your views, and also very curious about human capital, if it's being addressed, that segment of the population between 40 and 60. Thank you.
I can start. And yeah, so what we see from our data, and yeah, I think in this context, it's what's worth mentioning also such things as stigma. So what we see from different generations' perspective. So young people and people in their like mid 20s, 30s, they are more willing to get help. So they see more value in this, and even more they actively seeking for help. So they like have like a very clear view on this one. But with generations that are older, so sometimes it's even hard to explain like what does the psychologist do, and so there is like a big part of working with these people is through education, you know, like to provide them like teaching trainings, because like this is how their need for their care is generated. So yeah, so I wish there were like more psychological requests from the group, from the age group that was mentioned. Yeah.
Yeah, maybe I can also answer. So if you look at evidence, I think the careful studies that have looked at kind of the adult population and what is addressing their mental health do has largely focused on, I think, like postpartum women or pregnant women, and often like they're reached by CSOs. It's not any kind of formal program. So I do think, like, to kind of echo a previous question and Carrie's response, I think we do need to generate evidence and target programs for that kind of just regular old working age group. And how I think you need kind of two strands of research. One is demonstrating the economic impact of addressing mental health. I think that would really kind of make the economic case, saying, your current workforce, if you gave them mental health care, like this is how much more productive they would be, this is how much money you're leaving on the table, it's probably quite a lot. And just no one has rigorously quantified it. We have to kind of do these extrapolations and then they just become abstractions. But I also think, given what Olga just said, if it's very difficult for this population to accept care and kind of self-diagnose, then we also need to experiment with like different ways of reaching them, since they're not just going to walk into a clinic and say, I need help. And so I think that that's kind of a real research gap that would be worth filling.
Thank you. Next question.
First of all, like 3 years ago, I was in those meetings, and then second day, the war erupted in Sudan. I'm Sudanese. I used to work for the Ministry of Health. And currently I work for Yale as a researcher. My focus is on health in humanitarian setting, particularly non-communicable diseases, including mental health. And I'm glad to hear, like, you know, research gap, evidence-based. And you talk about like the scoping reviews, including like the Gray Literature Review. So congratulations to civil society. They're really good in finding, like, you know, putting themselves on the table. But I'm really missing the academia, like, I don't know, in the room or even like, you know, just to be presented and contribute to such great missions. So if you can tell me, like, from the experience in Ukraine, how did academia or like academic partnership contribute to this mission and work, and also like what we can do further in the future. And from some of the work I heard, social media a lot, and this is something I see also like in Sudan. How do we, like, you know, find many research questions and even the answers and data were on the social media? So are we able to capture all that, like, just to inform it and also like have the evidence?
So maybe I'll ask Olga Khan to answer the first question, where how academia is kind of involved in this, and then maybe Olga Yudina can answer the second question on social media.
Yeah, sure. Thank you. Yeah, absolutely. I do agree. We have a large discussion on evidence-based approach in Ukraine, and there are so much kind of like personal initiative or small think tank groups which do work on small studies or well, different scale of studies. And then, as I mentioned, we have the coordination mechanism under the Prime Minister. We have the coordination mechanism which coordinate all ministers. And on that coordination meeting, on one of the coordination meeting, it was a large discussion that, okay, it's good to have these small studies. However, with kind of like more than 4 years ongoing active war, it will be good to have really serious studies. So it was created the Academia Consortium with 5 major universities from Ukraine with medical background, humanitarian background, education background, etc. And under this consortium, Ukraine take a step to have several studies which will cover all Ukraine and build the research which can share the result not by the small sample size but really wide sample around Ukraine and give major big results of the studies. So if it's interesting, I can connect with this consortium, and it probably could be a good initiative. But also, if I may, I wanted to address a few previous questions, speaking on investment from 0 to 13. I do think it's a big challenge, like to increase budget from 0 to 13 to so much. But I do remember we had such similar discussion in Ukraine about increasing or shifting budget of Ukraine to increase share to mental health. So again, actually studies and evidence-based approach helped us, because we did in pre-COVID time in 2019, we did study cost of mental health of Ukraine, which actually shows to government the ratio between how much Ukraine allocate for mental health and same amount of money cumulative Ukrainians spend on out-of-the-pocket medication, and then some other. This is the major findings I remember, but there are some other which actually help us to formulate a proper recommendation, if not change, but then revise and reallocate funds within the budget to which intervention will be more appropriate, and then after that reimbursement affordable medical program were created, which help to people to get medication for by reimbursement program for free. That's it from my side.
So I have to take the moderator's prerogative and actually no more questions, but you can certainly ask us after the fact, but we do have to vacate the room in just a few minutes. And so, and unfortunately, obviously, we do not have time to do our kind of breakout sessions, which I was really looking forward to. So I just wanted to thank everybody for your rich and thoughtful discussion today. I believe what we've heard today reinforces a central point, that investing in mental health is not separate from economic recovery, it's foundational to it. Whether it's considering productivity or workforce participation or resilience of communities, human capital remains at its core. And in that context, mental health is not only a humanitarian priority, it's a strategic investment in economic recovery and long-term societal resilience. So we hope today's discussion contributes to that ongoing effort, both within the World Bank, which recognizes that funding for psychosocial support in fragile states remains a fraction of humanitarian and donor budgets, and across your respective areas of work to elevate and accelerate the issue. So thank you again to the Civil Society Policy Forum, the World Bank, the IMF, this audience for your engagement and your insights, and of course our excellent panel and your continued leadership on this important issue. So thank you very much.
Thank you for being online, Olga.
Olga, sorry. Thank you. Well, because you told me I have to stop. I do what I'm told, but I want to get her because she had a question.
Recording stopped.
For 3 years, we've been supporting refugee families with Ukraine, like Poland, with disabilities.
Okay.